So here's our goals for today. Define what leading healthcare is, understand the underlying principles, and then describe the Theta Care results and the management system, which is, by the way, the secret sauce to the transformation is the management system, and that's why I want to spend some time. I actually am going to take you to the Gemba with a series of videos to show you what we actually mean by the management system. So just a little bit about what we do. I run the Theta Care Center for Healthcare Value. This is a not-for-profit organization, very similar to Anton and Norman's organization. We have an independent board. Some of you may recognize some of these names. Maureen Bisignano, for example, who is the CEO of the Institute for Healthcare Improvement. John Shook, who's the CEO of the Lean Enterprise Institute in Cambridge, Massachusetts, and a number of others. We are specifically focused on three things as it relates to healthcare. One is care redesign using lean principles. That's what we're going to talk about today. Two is payment redesign. So in the United States, there's a lot of changes going on, needed changes, frankly, as it relates to how we pay for healthcare. And then the third is transparency of healthcare performance. So we've been involved in a lot of public reporting initiatives as it relates to healthcare performance. If you want to check us out, we're at www.createvalue.org. There are a lot of videos and white papers there that can help you get into this work in a more deep fashion. So this is the way I consider healthcare reform is kind of one-piece flow. Let's figure out how to deliver value, let's figure out how to pay for it, and let's make it transparent to our patients. So I want to start with some results, because the only reason that we would consider using the lean methodology is to deliver better results for our patients. That's the only reason. And so here are some results that Theta Care has achieved in the last few years. We have a not-for-profit organization called Consumer Reports in the U.S. that reports now on physicians. And I'm from Wisconsin. Theta Care is in Wisconsin, and the physician group there has been rated #1. By the way, we compete with the Mayo Clinic, so we actually have beaten the Mayo Clinic, just for your information. So the Centers for Disease Control recognized Theta Care as one of the 9 best practices for high blood pressure management in the United States, and CMS recognized the Theta Care ACO. So what's an ACO? Accountable Care Organization. This is one of the changes in payment that's going on in the U.S., where we're now paying organizations to take care of populations of patients. So an accountable care organization is what Theta Care has been participating in, and they're accountable for 20,000 Medicare beneficiaries. And so the results on this accountable care organization performance, which there now are about 700 of these in the United States, showed that the Theta Care ACO is the best quality in the United States. And then from a finance perspective, we also showed over the years that we can dramatically improve our operation results, our profit results, as well as our bond ratings. I published this article in the Journal of American Medical Association in 2013 that showed this organization, this ACO organization that Theta Care is responsible for, actually reduced the total cost of care by 4.6% for 20,000 people. So, as you all know, the U.S. is the most expensive healthcare market in the world. We have a big problem. It's almost 18 and almost 19% of our GDP now. So it's very important that we begin to focus on improving quality and lowering costs, and we've proven now that we can start to significantly reduce cost using this method. Now, the other major medical journal in the United States is the Wall Street Journal, and the Wall Street Journal actually published this performance data as well back in 2013. So I say all that not to be patting myself on the back, but to be explaining that we now have good evidence that we can actually reduce the total cost of care for large populations of patients by using this methodology that we call Lean. And by the way, we're not the only ones that have been able to do this. We've seen similar results in the Palo Alto Medical Foundation in California. We've seen similar results in Seattle with Virginia Mason and Group Health and other places. So what we're finding is that organizations that are sophisticated in their understanding of these principles are really starting to deliver remarkably better quality and cost results for their patients. All right, so what do we mean by lean in healthcare? And by the way, my recommendation to you would be that you never use the word lean, okay? Certainly never use the word lean with frontline workers like nurses and doctors, because all it will do is make them mad, okay? So just don't use it. But for our conversation today, this is what we're talking about, okay? Lean in healthcare, the Toyota production system applied to healthcare, that's what we're talking about. But I'm not suggesting that you use this as the way to communicate with your caregivers, because they hate this word. And my caregivers hated this word, and so just, remove it from the lexicon. But here's the definition: an organization's cultural commitment. So that means we're going to change the culture of the organization. Many people think lean is a series of tools. I bring this toolbox out, and then I start using these tools, and then we're going to reduce wait time, and we're going to do this. But that's not exactly what it is. Lean is actually a cultural commitment to applying the scientific method to designing, performing, and continuously improving the work performed by teams of people to deliver measurably better value to patients and to other stakeholders. So we published this article in Mayo Clinic Proceedings a couple years ago, and I want to focus on other stakeholders, okay? Because it makes sense that we're going to focus on the patient. We're going to deliver better value. By the way, that's better quality and lower cost. But we're also concerned about our staff, our teams. And what we find, and I see this I've been to now 165 different hospitals and health systems in 17 countries, so South Africa is my 17th country. And what I find every place is that people do a lot of non-value-added work. They're constantly firefighting, running around, doing things that don't have to be done. And so as we redesign processes, these other stakeholders, like nurses, like technicians, like housekeepers, guess what? Their work is more meaningful because they're not doing non-value-added work as we take out those steps in the process that don't matter anymore. So it's important for us to think about this methodology as both improving the patient's experience and improving the caregiver's experience. And we've seen great evidence of both of those things. So we talk about the principles. This is actually work that comes from the Shingo Institute. Shigeo Shingo was a Toyota sensei. He worked mainly in the western United States. And when he retired, Utah State University gave him an honorary degree and created something called the Shingo Institute. The Shingo Institute then took all of the writings of Shigeo Shingo and put them into a format that we could sort of understand. And these are some of the principles that Mr. Shingo put together for this idea of lean. So it starts with this first floor of the house, which is respect for people. Now, some people think that respect for people means I'm going to go out and I'm going to shake my nurse's hand or my doctor's hand, so I'm the leader, I'm the CEO. How are you today? How are things going today? That's not what we mean, okay? What we mean by respect for people in this context is that we respect you, frontline worker, enough to allow you to identify and solve problems. So what we're saying is that we're going to give you the training and the tools to identify and solve problems so that all the problems aren't being solved by the manager. Because in most organizations today in healthcare, most of the problems are solved by the manager. But what we're suggesting is we need to create an environment and a team that can solve problems at the front line. The second floor of this house is scientific method. So we're going to use plan, do, study, act cycles. So for you clinicians in the office, or in the audience, right? That's what we use with scientific method to take care of patients. Well, we're going to use scientific method to solve problems that aren't necessarily clinical problems. We're going to use scientific method to solve problems with flow, right? With reducing wait times, with reducing defects. The third floor of the house is purpose. So as leaders, we have to make it clear to our workers what it is that we believe are the most important things to do. And we need to align the organization to do that. I'll show you some pictures of how that works. And then at the top of this is the leadership behaviors required. And as I always like to say, change is great as long as I don't have to. But what we know is, in this world of lean transformation, we all have to change our behavior. And I'll explain how personally that impacted me as a leader as we went down this path. So in that same article from Mayo Clinic Proceedings, we tried to simplify this house into these few principles. And so what I want to do is go through each one of these and give you some examples of what we mean by each one of these principles. So let's start with value. And it matches up pretty nicely. If any of you have read Jim Womack and Dan Jones' book, The 5 Principles of Lean Thinking, these principles match up pretty well with what those folks found in the automotive industry. Let's start with value creation for patients. So what do we mean by value? What we mean is that the quality and the cost delivery to the customer should be improving at the same time. So some people think that lean is a cost control activity. So if you go into this kind of transformation thinking with the idea that lean is a cost control activity, you will fail miserably. Okay? Lean is not a cost control activity. It's about delivering better value to the patient by taking steps in a process that are non-value added and removing them. Now, some people call that waste. There are lots of different ways we can talk about that, but the reality is that what we're trying to do is take the non-value added steps out of a process and deliver better value. That means that quality should improve and cost should go down. If you're only focused on cost, you won't get the full power of this activity. And then how we deliver that value is the steps in the process of care delivery. So here's a very interesting way to think of that. Most healthcare is designed, so if we're thinking of the journey of the patient in the back and how we're designed in healthcare in the front, right? Here's our silos, right? So this is the laboratory, and this is the X-ray department, and this is the medicine department. We have all these departments that aren't really focused on the patient. They're sort of focused on themselves. Healthcare is designed around us. Okay, I'm an internal medicine doctor, and I am in charge, and I want the process to be focused on me, not on the patient. That's our problem. What if we designed a system in which the patient was in front of these silos, right? So we're trying to move the patient along. The patient experience becomes front and center, and the silos of all of our departments are sub-optimized to a certain extent. Now, we can't get rid of all the silos, so we'll always have silos. But can we redesign those silos so that they're actually effectively managing the processes of care of our patients? Here's an example from ThetaCare. This is actually a value stream map with all the steps in the process from when a patient gets admitted to the hospital to when the patient gets discharged from the hospital. Now, this is the 7th iteration of the experience of the patient going through a ThedaCare hospital, the 7th iteration. And these circles here are where there's still massive amounts of waste in the system. In fact, when you blow out this circle at discharge, there still was 148 steps in the process of discharging the patient. This is after 7 iterations of redesign. It gives you an idea of the complexity of the environment that we're in. But it also gives you an idea of, wow, I can make this visual. I can determine that this step right here is a mess. So let's go deep into that step and start to take the waste out of that set of processes. This is the power of lean thinking, allowing us to start to think about things from the standpoint of the patient's experience, not from the standpoint of our vertical silos. So one of the things you all have to do is to get everybody on the same page, right? So we need to get the team members, the people that actually deliver the care on the same page. So how do we do that? How do we do that so we can deliver better value to that patient? One of the ways we do that is to make it clear as leaders what we think our people should be working on. Now, I don't know what it is in South Africa, how many metrics you have to report and all that kind of stuff. But in the U.S., we have to report all kinds of things to the federal government, to the state government, to all kinds of places. And the reality is most of those metrics are non-value added to the patient. They actually have no impact on patient care. So our challenge as leaders is to say, what are the measures that really do have an impact on patients? And can we all get together on what those are and start to work together on improving them? So this is what we call True North. This is ThedaCare's True North. So these are the things that we're all going to work on together, all 7,700 employees at ThedaCare in 7 hospitals. So let's take this one at the top here. I like to talk about this, preventable mortality. So I've done a lot of work on trying to understand medical errors in the world today. And the reality is that we injure and actually kill hundreds of thousands of people every year in the healthcare industry due to medical errors. And we did it at ThedaCare, okay? I mean, I had data. So 12 years ago, when we started down this journey, we had a conversation between me and our senior executive team, and I said to my senior executive team, isn't it the one thing that you would want us to do if you came in to one of our hospitals was for us not to kill you? And, you know, we're all kind of looking around at each other going, yeah, that sounds pretty good. This year in the United States, about 400,000 people will die from medical errors. That is unacceptable. As healthcare workers, that is unacceptable. And so 12 years ago, we made the commitment to ourselves that that is unacceptable. And that we are going to work on this thing so that we're going to reduce infection rates, we're going to reduce medication error rates, we're going to reduce all of the things that people die from in hospitals. And we've been measuring this through the hospital standardized mortality ratio, which I understand is not a perfect metric to measure mortality, preventable mortality, but it's one of the best ones we have. And we have actually dropped that now to benchmark, close to benchmark in the world. But it's because we focused on it. It's because we said, you know, here are the few things that matter. And it's because we were able then to deploy that throughout the organization so that every nurse, every physician, every technician knew that the work that was important was the work that was going to impact preventable mortality. So that's the purpose of True North is, you know, do we really know what it is that matters to us? as an organization. And there's some other important things up here. The DART score is days away from work restricted due to injury. So the ultimate respect for people metric is less than injure all of our staff members. And by the way, healthcare is a terrible industry as it relates to employee injuries. So that's another thing that's been really focused on at DataCare. So True North, what is it? What's our purpose? What are we really trying to accomplish as an organization? Our thinking really changed, and mine did in particular, when we moved to this A3 thinking. I want to explain this. Norman runs a A3 workshop, which I would highly recommend everybody attend at some point. Because what A3 thinking does is it makes you step back and ask the question, what is the current state? What's the background condition? And then what's the problem we're trying to solve? And I challenge you tomorrow to go back to your place of work and try to write a problem statement that doesn't have a solution embedded in it. And here's the trick. What's the what of the problem we're trying to solve? And then get your team together and see if you can agree on that. Because the point is that once we understand what the problem is we're trying to solve, we actually have a pretty good shot at making a recommendation or running an experiment to solve it. But what I see in most organizations is we haven't got any agreement on what the problem is. This little simple one-page sheet helps us to start thinking about what is the problem we're trying to solve, or what is the strategy we're trying to implement. At DataCare, we use this one-page activity, strategy A3, to actually deploy the thinking across the organization. So again, we're still talking about how do we get everybody on the same page. So at the front line, the cross-functional teams had their A3s. In the middle of the organization, which might have been the hospital leadership, they had their. And then the system A3 was, what is it we're going to focus on? Well, we're going to focus on safety. And we're going to build out a whole process around safety because we have a problem. This is another way that we can begin to get thinking from the bottom up. So this is not just a one-way street. It's okay, what's going on at the front line, and then how is it, how are we impacting it from a senior leadership standpoint? What about continuous improvement? So, we've got all these things, right? We got Pareto's and flow charts, and sometimes we get confused by all it. Does anybody remember what the problem was? And in fact, so do we. So there's a lot of things on this slide, right? But this is the fundamental thinking process of Lean. Plan, do, check, act, or plan, do, study, act. All of the tools, all of the processes, all of that stuff really comes down to this. And when people say, so what is Lean? I said, it's simply scientific method, plan, do, study, act, cycles applied to your daily work. That's all it is. That's all I tell anybody it is. Because that's the thinking that we're using to solve problems. This plan, do, study, act thinking. So what we're after is that frontline workers are solving problems and sustaining improvements. Frontline workers. So at DataCare years ago, we established that the major metric that we were going to measure the performance of managers on was how many problems staff members identified and solved on their own. That was the metric for manager performance. It wasn't financial, it wasn't any of this other stuff, it was number of problems identified and solved. Here's an example. This is a picture I took a few years ago on the medicine unit at one of the hospitals at DataCare. And you can see they had, the goal for 2011 was 900 improvements. Okay? And you can see how they were tracking to it, each month. 80, 90 improvements a month. That year they had 33,000 improvements identified and done by staff members, not by managers. That's a culture of continuous improvement. That's what we're after. But we have to make this all visual because it doesn't actually work if you put it in the computer. So here's an example of a visual control board. Here's that triangle I showed you, that theta care triangle. This would be the level of the driver metric. So what are you working on this unit that's going to drive to that particular performance measure? Here are a couple of the A3s that they're working on that had either been deployed or they were working on their own problems. And then these are the slips for improvement over here. So every day they meet in front of this board and new ideas are bubbling out of the staff, okay? And the manager's job is to make sure that those ideas keep coming. This isn't some kind of fancy computer program, by the way. You can see this is handwritten in pencil. That's what you're seeing on this board. Every day people are going up and writing this stuff. How are we actually performing? And it's the nurses that are doing it, technicians, the housekeepers. We also have a lot of electronic stuff, and you can tell here, here's how we're flowing through the process today. We got a red, some greens, but most of this is actually very simple, non-technical visual management. So what about standard work for administrative and clinical processes? Is standard work a bad word in South Africa? It's kind of a bad word in the U.S. Because people, the doctors in particular, say, well, you're going to take my creativity away if I have to practice with standard work. But yet medicine is all about standard work, right? We use the evidence all the time. That's how we treat patients. Why wouldn't we use standard work for everything else that we do for patients? It's part of the problem is we don't have standard work for most of what we do when patients come to the hospital or to the clinic. So years ago, Data Care created some standard work, some new standard work, and the reason was that we were performing very poorly. We had mistakes being made, medication error mistakes. Patients were waiting hours at a time to get from the emergency room to the inpatient care unit. And so a few people got off, we gave a few people some time off of their jobs to step back and say, what would a better inpatient care process look like? And they actually came up with a completely redesigned inpatient care process. And this is the set of standards that were created. Again, it's not very high tech, is it? I mean, different yellow colored stickies, if you call that high tech. But this was the set of processes that those clinicians, and by the way, there were pharmacists and physicians and nurses, technicians involved in this redesign. And this is how the process works. So they created a series of toll gates for every disease process. So let's take pneumonia care, for example. The first toll gate in pneumonia care is the oxygen level at the appropriate, at the appropriate level. Okay, so is the patient oxygenated effectively? Have the antibiotics been given in the appropriate time frame? So that's the first toll gate. If it hasn't, then we stop, study, and adjust to make sure that we meet those quality performance criteria. Then we go to the next toll gate, and the next toll gate, and the next toll gate. So they built 5 toll gates for every single clinical condition based on evidence, clinical evidence, right? In the States we use something called the Milliman guidelines, but there are many different types of clinical evidence guidelines throughout the world. And we built these toll gates, but the point was we were always problem solving if we weren't meeting the criteria that had been established for the quality of each one of those toll gates. So we did this for a few months. We ran this experiment in 12 beds in one of our hospitals. Not hundreds of beds, 12 beds. A small test of change experiment. And we ran it for 11 months. We had 1,500 patients in the first year that went through this new process of standard work. And this is what we found. That when we started, we had 1 defect per patient stay as it related to medication reconciliation. So we were 100% reliable at being unreliable. Okay? Which is why we did this work, because we were unreliable. But in this first year when we actually ran it, we basically went to 0. And for the next 9 years, actually we have data that goes through this year now, we've had 0 MedRec errors in this collaborative care unit. 0 for 9 years in a row. It proves that this set of standard work that we've been creating using this methodology can get us to 0. Now the reason, and you can see dramatic patient satisfaction improvement, you can see significant length of stay drop, cost improvement, 30-day readmission, which actually has now dropped about 4.5%. Why did we stop at 2010? Because we were comparing ourselves to ourselves. So by 2010, every unit now was using this new standard work process. So we stopped measuring it. And I think that's a very interesting point, okay? When you measure your performance, you should measure it against your existing current state, not some benchmark over here of some great hospital, blah, 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 okay? First of all, there is no Toyota in healthcare, so you shouldn't have any benchmarking as far as I'm concerned. What we should be doing is saying, how does our new process compare to ourselves? So from one med-surg unit to the next med-surg unit, from one surgical unit to the next surgical unit. As you try these small tests of change in 12 beds, is it actually better than all of the rest of the departments? Because as you start to improve in these other departments, as you start to improve in this, small test of change department, then the expectation is going to be that we move all of the departments in that direction, which is what happened here, okay? So by 2010, every one of the units was using this process. One of the things we did to make this a lot more possible was we built a different supportive environment. And we didn't build a new hospital, but we did build these nurse servers that go in and out of the rooms. And same thing here with the laundry. And the medicines are in here. And so what we did was by building this and creating a Kanban system, which meant that every single supply a nurse needed was always there, then we could make sure that the nursing staff was in the room taking care of the patient all the time, rather than running around looking for things. Because they run around looking for things all the time, right? If we could reduce that, we could actually improve and get some of these results. So that was an important part of the environmental change to our process. And you can see that these things have continued, our length of stay has continued to drop. It's now about 2.4 days. And this is old data now, but 5.3% 30-day readmission rate. Okay, but here's the real problem as it relates to standard work. Clinicians can understand standard work. They can understand it, and when we teach it, we understand it. But you know what? Managers and executives don't have a clue. And that's the problem. There are no standards for managers and executives. And in fact, Peter Drucker, who I love this quote. I read all of Peter Drucker's work. Peter Drucker actually worked with Toyota in the 1970s to help rebuild or to improve their management system. Most of what we call management consists of making it difficult for people to get their work done. I was a clinician for almost 20 years. This is exactly what I thought of management. Okay? I was an internist, and one of the operations directors would always come to me every year from the hospital and say, "Doctor, how can we make your life better in the hospital?" And I'd say the same thing every year for almost 20 years, and it never changed. Okay? So I really believe this. So the question was, why couldn't that vice president of operations ever fix the one thing that I asked for 20 years? And I finally figured it out. They didn't have any system. They didn't have any standard work. They didn't have anything. They were just flying by the seat of their pants, trying to get through the day every day, just like me, the doctor. So what we needed to do was create some standards. in management. And that's what we've been really working on. That's why I say this is the secret sauce. Because if we as managers and executives can actually figure out how to build a system that works for our frontline staff, then we can start to see them identify and solve problems every day. If we don't do that, they don't have time, because they're just running around like chickens with their head cut off. So here's the system that we've been working on, and I will admit it's a work in progress. We do not have all the answers to this system. But one of the core elements is the CEO is not on the top of the org chart. Okay? The CEO and all these other fancy-dancy people are there to support the people that are adding value to the patient, not the other way around. Now, there are different roles and responsibilities of these two sets of people, right? So if we look at the leadership, what's the role? True North, I just explained True North. Does everybody understand what the purpose of this organization is? What is it that we're going to work on? Strategy. Not 100 strategies. I was at a hospital 2 months ago. I asked them to write on a yellow sticky all the strategic initiatives that they had going on in the organization. 358. 358 strategic initiatives. How can you have 358 strategic initiatives? I mean, no wonder everybody's running around like they're chicken with the head cut off. Just a few. What are the 2 or 3 things we're going to get accomplished this year? What are the 2 or 3 things we're going to get accomplished? Our job as leaders is to identify the barriers our frontline teams have in taking care of patients and remove them. That's our job. Remove barriers. And then become a teacher and a mentor. And we have to learn how to become a teacher and a mentor, because the reality is we usually don't know anything when we start out on this journey. So I had to learn. It took me a lot of work. Coaches came to help me. Many coaches said I could not be helped. I've been working on it for years. My staff still say I probably can't be helped. And then what do we expect from the front line? So continuous improvement. I mean, these people are identifying the problems. We want them to solve them, right? So we have to create a system for them to be able to do that, to continuously improve every day. We want them to, they're the ones that understand how we're performing, so the metrics, the measurement is important. So they're gonna focus on, I showed you the handwritten metrics, right? And then if they can't solve the problem, they got to get it to the right level. So we encourage them to solve most of the problems, but sometimes they can't. So I'm going to show you a video now. This is a video of that visual board that I showed you. So every morning, and this is in the surgery department, okay? Every morning the manager comes in and does something. This is part of the standard work for management. And this happens every morning in every department throughout the hospitals and all the clinics.
That's just off of the wall. Nobody's allowed. Good morning. Yeah, we're gonna start in this corner, then we're gonna talk about some of this, and then we're gonna work our way down. So, okay, let's start at looking at our work in progress. So we have quite a few works that we have going on right now. Michelle, this one is talking about cross-training, actually crossing the OR to get the gloves multiple times.
Right.
And we wanted to decrease the amount of traffic moving back and forth, so we're gonna relocate some of those glove boxes onto, where were we gonna put those?
The coning tree. So that we don't have to keep going back and forth getting
Okay,
gloves,
right.
I'll just keep those right there.
Great
Put-
suggestion. Okay. So I guess the action for that one is, how about if I put in a work order for Dave to have him attach it to the sponge holder itself? Do we want that in all of the rooms? Do we want that in the heart rooms also? Because that's where you actually, all of the rooms, so 1 through 6? All right. And we'll make a note of that. All right, so the next one, we're looking at, Melinda brought up the issue that it's difficult to find to tie missing instruments to the actual patient. And I know that, Carla, you were working with her on this. Multiple PANs, multiple patients with the same procedure. So you and Melinda were talking about some sort of clip system.
Yeah, bringing back the clip system that we used years ago.
So they're color coded?
Color coded, they go on the count sheet and then in each pan. So when they run through the system, then they'd be easily put back together. They would know what went with that sheet.
You were helping with that too, Carla.
Yep, we've already started doing that for open heart.
Oh, so you're trialing it in open heart. Great. How's it going?
I haven't heard anything so far, so.
Okay, so the manager, this is the manager right here. How is she acting? Is she telling him what to do? What's she doing? Engaging them, asking questions, right? The team has the answers, right? And what her job is, the manager's job is to pull those answers out, because they have the answers. They have way better answers than she does, okay? So that's the idea here. That's standard work for management. We're going to have this huddle every day, and I'm going to pull out from you, team members, the ideas to improve the care delivery in that operating room. Okay? So here's another one. There's something in manufacturing called an and-on cord. Those of you that have visited Toyota plants will have seen that the worker, when there's a problem, pulls a cord and a light starts to flash. And that usually draws the supervisor to the place where the light's flashing. They have 60 seconds to solve this problem that the worker has identified. And then if it's not solved in 60 seconds, the whole line stops. And then there's a whole other set of lights that goes on. And the plant manager actually comes down and starts to work the problem. This way, no problem is ever passed down to the next worker. And that's why Toyota's been able to create such an amazingly high-quality product. So what would that look like in healthcare if we actually pulled the cord, okay, and said, hey, we got a problem. We need to fix it right now, not wait 60 days until we can get the quality committee to come and meet, right? Which is what always happens, in which we never solve anything. So this is what we call, this is an and-on pull. Now this video, I'll warn you, is not very good. I took it with my iPhone, okay, so I go out with my iPhone all over the world and I take these videos and everybody hates it because they know they're probably going to show up someplace in some conference. But this was on an oncology unit, and this is the woman in the middle here is the manager of the oncology unit. So a nurse pulled the and-on, and you can listen from here.
The same last name.
One collaborative, one over
And
here.
similar first name.
And it's a highly unusual last name, which makes it even more odd that this should happen. So the defect is prepping wrong patient.
And it also delayed her discharge, because she was supposed to be discharged yesterday until they received the order and said, we're gonna do an EGD later.
When you say she,
Which
the patient? Or the two patients, if that really doesn't happen.
It was actually, the order should have been given to the nurse for the patient over there, and they were given to the patient over here's nurse, so it delayed her discharge.
And I tend to wonder too if part of the problem was that they have our old room numbers.
You know what, I was just gonna say that.
Oh.
Is it that, is it the wrong room? You know, that they were thinking.
357 over there.
How would we prevent this from ever happening again? Tough question, but how do we ever prevent it? Because this is the second time that we have received orders for the wrong patient, and it did involve NPO and scoping. This time, the names are identical, and the first names both start with D.
The medical record number.
Doctors don't know that.
So when a physician is calling in an order,
You always have to repeat the order back to the physician, but I don't know that I say, okay, this is for so-and-so, and then, but I always say, okay, you want, and I give them the drug, and, you know, you're supposed to always repeat back the order to the physician, but I don't know that I repeat back the patient's name.
This situation, even if you repeated that name, I don't know if the physician would have even identified it.
I agree. So how's
Because
this
they
ever
were
gonna happen
that
again? Because we have, and we don't have the awareness that there's another patient that has the same exact last name. So repeating orders would help.
Wouldn't even necessarily.
Yeah, we, and if
So-
we had no idea, how would we stop that?
So when we receive orders, what do we require of a physician so that we know that we have the right patient? What do we require? Just the last name?
What's the last name is?
Like your 5 rights.
Okay?
But I don't think it would have mattered in this situation because of how similar that it was.
Well, we're always supposed to use 2 patient identifiers. So if we're administering medication, we're using 2 patient identifiers. So when we're receiving that order, what are our patient identifiers? It sounds to me like we're only using 1. Okay, so do we need to relook at that? I know we read back the order, but I'm wondering if we need to relook at what's required for identification when receiving an order.
Which is, would the doctors know the birthday though, if they're calling you on
Well,
phone would they know the birthday?
I don't know that they would, but is that,
Can they access it fast?
how do we confirm that if we're not using 2 identifiers, how can we confirm that we have the right patient?
So this took 2 minutes. There were 2 problems identified, right? Room number problem, 2 patient identifier problem. Did you hear that manager ever tell those people what to do? She patiently is trying to pull out what the problems are, right? So the nurse that actually identified the 2 patient identifier thing was given 2 hours that afternoon to go down to the endoscopy lab, look at the existing standard work for this, rewrite that standard work, and then on Monday begin to train all of the rest of the team in the new standard work for prepping patients for endoscopy. So we solved the problem. We didn't pass it on. Same thing with the room numbers. The nurse that identified that called the environmental services people up. They changed the room numbers that afternoon. Okay? So this is the process. So this is the management by process that we're talking about. And if we don't have managers and executives eliciting these kinds of behaviors, we're not going to support the people that are actually doing the real work. So I want to show one more video very quickly here. This is the standard work between a vice president, VP, vice president. These are the questions that vice president's going to come to the floor and ask the manager, okay? So this is a conversation. Now we're going one up step, right? We're going from the manager to the vice president. So now how does that interaction happen? Well, first of all, the vice president has to come to the floor. Can't sit in their office all day long. They have to come to the floor and have this conversation. Again, this is not a professional video. This is taken by my iPhone. And this woman here is the manager, and the woman that will come into the left-hand side of the screen is the vice president.
So Karen?
Yes.
My first question is, how are our patients doing today in terms of risks? Do we have families or patients at risk?
I never read that.
All right.
Do a patient safety issue that showed up today.
Okay.
Anne brought it to my attention. It's an issue of a patient who is on Coumadin
Okay.
and received supplemental medication for something else related to their head and neck. And those 2 medications don't do well together, but it was filled at an off-site pharmacy.
Okay.
So, and then the patient was readmitted for an issue to the ER. For bleed.
So tell me how you were analyzing that problem.
Anne came to me with the facts. Here's what happened. Here's the sequence of events. And because of the readmission to the ER, we called Mike Beal
Okay.
and said, Mike, what do we do with this? Where do we go? How do we handle it?
So you triggered the medical safety officer.
Yeah.
Did you also start something in the department in terms of root cause analysis?
We're going to root cause their physician nurses next week. So we've got this scenario documented, but we need everybody at the table. We're forwarding Mike the information. He is going to start the conversation with the independent pharmacy. Because apparently there's a couple other pharmacies that he's connected to in this way that he started those conversations. How do you want to receive the information from us? What would you like to see differently available on our end? That kind of thing.
Okay.
And then he's going to forward our scenario to the folks working in the INRA3, because what I'm concerned about is we're an outpatient clinic, but we're considered part of the hospital. And we don't always fill from this pharmacy, and our physicians aren't taking care of physicians. So I'm not confident we're gonna get plugged into the work that's happening. So he would help us do that.
So you have a plan in place, and you'll keep me up to date.
Absolutely.
So again, we didn't hear the vice president telling the manager what to do, did we? In fact, the manager said something very interesting. You may not have heard it. She said, when the vice president said, "So do we have any risks today?" The manager says, "I'm so excited I have a red dot." Now let's be honest. How many of you would be so excited we have a red dot today to talk to your superior about? In a continuous improvement culture, what we've been creating is this idea that when there is a red dot, it's good, because it allows you to identify and solve the problem immediately so it doesn't get passed on to the next patient. That's the thinking behind Lean, is visualization of problems so that it doesn't get passed on to the next patient. And these are critical types of thinking changes in the system. This is just the way we measure. So all that standard work, we're going to actually go observe it to determine whether it's being followed, because the nurse can put the new standard work in place for the endoscopy lab, but if nobody follows it, who cares? So we actually have to go observe workers to determine whether the standard work is being followed. Not to check on them, but to check on the standard. Because actually the worker usually has a better way of doing it over time. And then finally, respect for people. Not finally, that should be our first thing. But again, we're back to our principles here. And one of my mentors in this was Paul O'Neill, who was the former Alcoa CEO, made Alcoa the safest company in the world, and also the former Treasury Secretary of the United States. He told me years ago, you have to say yes to these three questions. Are my staff and doctors treated with dignity and respect by everyone? You have to say yes to this every day. Do my staff and doctors have the tools, training, and encouragement to do work that gives their life meaning? Now, I think, my hypothesis is, if we as leaders came in and used that second question every day, we would lead differently. We would lead differently. Do the people that I'm responsible for have the tools, training, and encouragement to do work that gives their life meaning? And finally, can we just celebrate, say thank you for all the great work our teams do every day? They avoid a lot of problems by their heroics. And what we have to do is now build systems so they don't have to be heroes. And this is what I learned was, here's how I was trained, okay? So when we think about it from a leadership behavior standpoint, right? I was trained to be all-knowing, in charge, autocratic, buck stops with me, impatient, blaming. That's how I was trained. That was the behavior modeled for me by my professors. Okay? In this new world, look what we have to be. Students, teachers, mentors, coaches. Totally different. 180 degrees different than the way I was trained. That's why this is hard. Because change is great, and I have to. And this has been very difficult for me to move from this side to this side over the years. And finally, why are we doing this? Because we want everybody to be a problem solver. If we could unleash the creativity of the thousands of staff members that work in hospitals here in Johannesburg, just think what we could accomplish. Thank you for your attention.
Thank you very much, John. As a small token of our appreciation, and we have time for 2 questions. Anybody want to ask John a question?
Just one.
One will do.
No, I'm joking. One of the things that we struggle with is that most of the time in the hospital is out of hours. your managers have gone home. Now, how do you pull the cord at 2 o'clock in the morning? Because that's when the things fall apart. And how do you build standard work to create with your relatively junior leaders who are around at that time of the night?
Right. So the question is, how do we, since a lot of things happen in the middle of the night, and if the manager's not there, how do we make sure that these processes are actually in place? So that's a great question. And it does, you already started to answer it, right? So the junior members of the team, there needs to always be someone, 24 hours a day, that has the responsibility of managing to standard. Now, I'm sure, as it is in your place, there's always a manager on call in case there's something that person can't do. But it gets back to the training and the expectations. So every shift, there needs to be, training for the person who is going to be, managing these processes, whether it's an and-on cord, or whether it's a huddle, or whether it's any of these other things. And there has to be, on every shift, somebody capable of doing that. And you can't just hand it to them and say, here, go read the book, good luck, right? I mean, that's what we do in healthcare. You get a manager job and say, good luck, you're a manager now. Go be a manager, right? What we need to do is train them to be effective, okay? So if there is a supervisor or a lead nurse, for example, that's the leader during the middle of the night shift, that person needs to be trained in the standard. And if you are in any management role in theta care today, you have 4 months of in-the-work training to learn these processes. And if the book Beyond Heroes out here is Kim Barnes, who was the theta care president of the hospital who developed this work, it very specifically outlines the detail behind what manager's standard work is and what supervisor's standard work is. And that is trained in the work in 4-month modules. In fact, if you come as a new manager, you're an interim manager, or an interim supervisor, or an interim cell lead until you have proven competency in all of the elements of the management system. And if you're in Toyota and you get the plant manager job, guess what you do? You go to Japan for 4 months, and you're out on the line and you're learning the management system. So for us to think that people are just going to naturally figure this out, no, we've got to teach them, we've got to train them. Whether it's, the people that are working in the middle of the night or the people that are working in the middle of the day, they still need to be taught and the expectations need to be set. And that's what we don't do well in healthcare today. Does that answer your question? Yeah, thank you, John.
It strikes me that there's an inherent tension between, I think, what's pervasive in the current public sector in this country, which is where quality is largely understood as quality assurance and quality control, and a plethora of core standards that are imposed from the top down, and the kind of change that you're talking about. So how do you make that shift?
Right, so the question is related to quality is considered more around sort of the plethora of standards that are coming down from the government versus, making the shift to the continuous improvement culture that I showed you. So don't think that we don't have a lot of standards or quality assurance things that come down from our federal government. We've got lots and lots of them, okay? So we actually have a whole department that just manages our federal government standards, all right? So my suggestion to the government is make sure the standards are meaningful to patients, because most of the time they aren't. So can we step back and look at that? That's not the essence of your question. But I think that we need to, from a standard standpoint, meet the standard. Standards generally that come from governments are usually the minimum standard. If you really want to get to high reliable care processes, you need to have way more than that. And so quality assurance is one thing. We actually separated our quality assurance department from our lean transformation because, yeah, we have to do this basic quality assurance stuff over here, but what we really want to do is build a culture of continuous improvement. So our standards are led by the Joint Commission. So most of you heard about the Joint Commission. And what's interesting about the Joint Commission is they come and they review theta care about every 2 or 3 years. And what they do is they come in and they write new standards based on what we're doing. So a lot of the things that have come out of the Joint Commission are stuff related to not just our hospital, but others that have applied the lean methods. So I think we're going to see improved standards from the thinking of what standards mean. And in my mind, it's all about, having frontline people identify and solve problems every day. And rather than having a 60-day quality committee meeting, that's a standard. I can guarantee you a 60-day quality committee meeting is not about quality. Okay? What you just saw is about quality. We're identifying, solving problems every day and not passing that defect on to the next patient. That's what we should be focused on. Yes, we have to meet government standards. Okay? But if we're really going to make a difference for our patients, we have to get focused on identifying and solving problems at the front line. And that's what this methodology is all about.
Thank you. Last word of thanks.
Thank you.